Welcome back. I hope you're ready for some more interesting questions, and this time on the knee, the foot and the hip, of course. As usual, multiple choice questions. Minimum one answer is correct, maximum all answers are correct, so that's quite a challenge. I advise you also to open your PDF file, which is attached to this film, so then in a relaxed situation you can look for the correct answers. Okay, let's start. Let's start with the hip. Resisted hip flexion, maximal isometrical contraction, is painful. What could be the reason? Pain on resisted hip flexion. Okay, what do you think? Actually, the three last options. You could have a psoas muscle lesion. You could have a rectus femoris muscle lesion. But if the patient has an acute psoas bursitis, you may be sure that the hip flexion will also be painful because of compression on a very inflamed and swollen bursa. Yeah? When there is compression on a nerve root, your hip flexion is not painful. Your hip flexion could be weak when we talk about a big compression, but it's certainly not painful. Yeah? The details in orthopedic medicine are always very important. A pain felt in the lateral aspect of the thigh or the hip can be caused by which options? Well, here you have to come back to your knowledge of the basics in orthopedic medicine. Remember, we talked intensively about the rules of referred pain. Referred pain is segmental, mostly. An L3 structure is going to refer pain in the L3 dermatome. A C5 structure is going to refer pain in the C5 dermatome. But the exception, of course, was a dura mater. The dura mater, there we had multi-segmental reference of pain and tenderness. So, with this knowledge, if you come back to that question, okay, what do you think? An L4, L5 nerve root compression, because this is the specific dermatome. Tractus iliotibialis lesion, a bursitis trochanterica, all of those can cause lateral pain. The sign of a buttock is a red flag sign in which case? I refer to the specific film on the sign of the buttock, which you find somewhere on this platform. But you remember what was the sign of the buttock? The hip flexion is more limited and painful than the straight leg raise. So it was important when you do a lumbar examination that you always perform a passive hip flexion immediately after straight leg raise. Otherwise you don't discover that. So hip flexion, more painful, limited than straight leg raise. If this is the case, what do you think of? Pick a choice. Well, fractured sacrum and osteomyelitis. Anyhow, when you find the sign of the buttock, the first step is medical imaging, further checkup, further control. Okay? Let's go to the knee. Let's imagine there is some local, sometimes shifting pain, sudden twinges, perhaps a momentary blocking in the knee, and a certain apprehension on going downstairs. When you hear that in the story, shifting pain, remember, shifting pain is always a shifting lesion. So shifting pain, twinges, temporary blocking, a feeling of instability, a feeling of giving way. What do you think of? Okay, by now you should know the answer. So the most obvious things are loose body in an arthrotic joint and the most common meniscal problems. For instance, the bucket handle meniscal problem, the clinical image is a little bit different. This is much more acute, this is totally different. Yeah? Okay? In which case do we expect a capsular pattern? Remember, the capsular pattern in the knee, flexion is more limited than extension. And if you have a muscle spasm and feel, then of course you come to the conclusion of a very nice arthritis in the knee. But okay, pick a choice. When do we find the capsular pattern? Well, in an acute sprain of a medial coronary and an acute sprain of a medial collateral ligament. Remember, when we have a very nice ligamentous lesion in the knee, automatically we get a post-traumatic capsular reaction. With acute ligamentous lesion, you get the image of a traumatic arthritis plus the ligamentous lesion. And during the evolution, this post-traumatic capsular reaction is going to disappear slowly but surely, and the primary ligamentous test is going to become more and more obvious. Yeah? I refer to the specific chapter on ligamentous lesions in the knee. The treatment of an acute sprain of the medial collateral ligament consists of, okay, pick a choice. The important word over here is acute, an acute MCL lesion. What are we going to do? Well, the second option. We are not going to stretch yet. Yeah, remember from other questions, in acute lesions you don't do longitudinal stretch. Except for a tennis elbow type 2, but that's an exception. Huh? But in general, you don't stretch too soon. So we're going to do deep friction from two different positions, and we're going to combine that with active mobilization. Very basic. From the moment when it's possible, when it's not too painful, you also do proprioceptive exercise. Of course. And a few more questions on the foot. Mid-tarsal supination is the primary test for which structures? So we had some tests in the forefoot, yeah? Flexion, extension, abduction, adduction, pronation, supination. Supination in the forefoot was the main test for a very popular ligament when we talk about inversion traumata in the foot. Which ligament? Of course, the calcaneocuboid ligament. A chronic lateral ligamentous lesion can be treated by, so we have a chronic ligamentous lesion. What's happening? Probably there is a problem with scar formation, with adhesive, less mobile scar formation. I refer to the films on the basic principle on orthopedic medicine. So, but with this idea in the back of your mind, what are you going to do? Of course, you're going to do this. Friction massage, manipulation, proprioception. In other words, you're going to re-trigger the healing process by doing friction and one manipulation, and then you continue with friction and movement, movement, movement in order to get a more optimal repair and remodeling phase. Which of the following treatments can be considered in case of a recurrent valgus sprain? So not an inversion trauma, but an eversion trauma, which is of course less frequent. But what do you suggest we do? What could we do? An important little detail, recurrent valgus sprain. So perhaps there is some kind of malpositioning. There's a malpositioning in the subtalar joint There's already a valgus position in the subtalar joint which needs to be corrected. So perhaps that's one option. But if you get too often a sprain in that direction, you can also irritate your tibialis posterior tendon. So that can go together with the tibialis posterior lesion. And in that case, you're going to do friction massage for the tibialis posterior. What about the deltoid ligament? Well, a real sprain of the deltoid ligament is very, very, very rare. The deltoid ligament is so strong. Mostly you first have an avulsion fracture instead of a ligamentous lesion over there. No? So keep that in mind. What's the capsular pattern of the subtalar joint? Well, when you look at the film on examination of the foot, I explained that to you. Remember, visualize elderly ladies with rheumatoid arthritis. They are standing and you stand behind them. Look at the position of their feet. Their heels are in that position. Their heels are in a valgus position. So the capsular pattern, increasing limitation of varus with finally fixation in valgus. Yeah? They're blocked in valgus. They don't have varus anymore. A very beautiful capsular pattern. So I hope you enjoyed those series. Up to the next ones.